Society and Mental Health, and together with Tessa Roberts, I'm very excited to welcome you and our speakers to this conversation. Please be aware that the session is going to be recorded today, and you can turn off your camera if you don't want to be visible. Next slide, please. Our event today explores the question, how can global mental health better consider the social context in which mental health problems arise, acquire meaning, and are responded to? This session grew out of the desire to bring the concerns that we develop here at the Center for Society and Mental Health to the work that is being done to promote mental health among diverse and global communities. At the center, our strength is to think about the ways in which social life worlds and social determinants like housing, income level, education, gender, and power intersect with mental well-being. This conference more broadly speaks to many of these themes we consider important in shifting the narrative towards a better understanding of the social drivers of mental health.
Thanks, Dörte. It's great to be here in such good company. I'm Tessa Roberts. I'm a postdoctoral research fellow here at the Centre and a member of the Centre for Global Mental Health. For those of you who aren't familiar with the term global mental health, it's a subfield of global health research and practice that exists in part to address an imbalance between where most mental health research is conducted and where the majority of the global population lives. It's estimated that over 90% of mental health research is conducted in a handful of high-income countries in Western Europe, North America, and Australasia, even though these countries only account for around 15% of the world's population. We know these settings aren't representative of the rest of the world in terms of economics, culture, social norms, and so on. So if we want to improve public mental health for all populations, we cannot just study this small range of settings and assume we can extrapolate our findings globally. At the moment, the Centre's work focuses primarily on the UK, but as it develops, we want to partner with organisations and communities in contexts that have been historically underrepresented to support the application of a more social perspective on mental health in a broader range of settings. And this can generate new insights that might not be obvious if we just limit our view to Western Europe or North America. It's worth acknowledging that there have been many critiques of global mental health. One critique is that the field has focused disproportionately on individuals rather than on structures, societies, and contextual factors, and that it offers mostly individual biomedical responses to mental ill health that don't address the social factors that we know make a huge difference to people's well-being. Global mental health has also been critiqued for offering top-down solutions that don't always harness community strengths and local knowledge. So in this session, we hope to engage constructively with some of these critiques and open up a discussion about what taking a more social approach to global mental health would involve in practice. We hope that by the end of the day, we will have generated some ideas and debate about what a renewed agenda for global mental health could look like that applies a broader social lens to studying mental health around the world.
Thank you, Tessa. If I could have the next slide, please. So the goal for this panel today is to identify priorities at the intersection of mental health, society, and diverse communities. We are fortunate to be joined by a group of renowned speakers from around the world who will present their perspectives on global mental health through the lens of their projects. But we also really want to hear from you. Your expertise and your experiences matter greatly to us. And in this large forum, it is perhaps difficult to have an in-depth conversation with each other, but we're hoping that technology will allow us to draw your views into this conversation. We're going to use an app called Menti throughout the event, where you can enter your comments and questions to the speakers throughout. So today will be organized around 2 panels with each 4 lightning talks, followed by an open discussion after each panel that will be drawing on your comments and questions in Menti. And by the end of it, we will have a key message crowdsourcing exercise from you. To enter questions and comments, please go to the menti.com website now and enter the code below, which Nathan will also post in the chat for you to copy and paste. And we look forward to your feedback and reflections. And please also indicate the name of the speaker if questions are directed directly to one person. After each talk, we will also leave a little bit of room and time to really share your reflections in Menti. So without much further ado, it is my great pleasure to hand over the floor to our first speaker, Dr. Rochelle Burgess. Rochelle?
Thanks, Dörte. Hello, everybody. It's really wonderful to be here. My name is Rochelle Burgess. I am a lecturer in global health at the Institute for Global Health at University College London. I am a community health psychologist, and for those who are unfamiliar with what that means, it is a branch of psychology that is interested in driving forward community-led approaches to change that relate to health, and specifically highlighting the importance of social change and social movements, or as I've titled them in today's talk quite provocatively, the idea of revolution, and how that is a huge part of what needs to happen in order to change the landscape of, of mental health, and specifically looking at what is possible in order for people to be able to achieve good mental health and well-being. Next slide, please. So my work over the past sort of decade or so has been focused on trying to bring the praxis of the movement of global mental health more in line with the voiced concerns of people on the ground. And as part of doing that, it has sort of been rooted in a reconceptualization of community, and to move the idea of community from a place of a locus of action that is envisioned as specifically geographical or linked to identity, to think about broader structural realities around community and community life. And I think the quote on this slide is actually from a more recent piece of work, a comment that I wrote around the lack of social responses to mental health consequences of COVID-19, but it's very much been part and parcel of my work for many years. In my life, I use participatory, qualitative, and ethnographic methods, which try to bring me as close as possible in collaboration and partnership with people who live and survive difficult circumstances, with the aim of understanding survival as a route to defining change and paradigms for change. And one of the things that has resonated in my work across many countries, high income and low income countries alike, is that we really do struggle to enable good mental health in contexts where we are missing security, food, shelter, safety, and many things that we often think about and align with this idea of social determinants of good health. And while the social determinants paradigm gets us some of the way in thinking about how to better engage with the social in terms of mental health, what often happens in praxis in terms of the space of interventions is that the socio-structural, so all of these realities sort of linked to this quote, gets left behind. And we focus on socio-relational dynamics, so improving relationships or thinking about people working individually to solve problems. But ultimately, when you look very closely and listen to the stories of people who are surviving through everyday circumstances or crises circumstances or any circumstance, there's a clear consensus that you cannot separate the socio-relational and the socio-structural. They are part and parcel of each other. So this has led my work, sorry, next slide please, to look for new paradigms and frameworks of understanding the social. And for me, this has really resonated with this idea of political economy and socio-political economy. And in working with others, some of who are actually on the panels today, and the next speaker actually, we've been trying to think through how we can better encapsulate and come to terms with how social determinants actually feed into each other and drive complex patterns of inequality, poor access, and sort of social pathways to development of all kinds of distress. And when looking at things within a paradigm like this, it makes it quite clear that we are unable to work at the level of the individual to really get to any sort of point of traction with moving sort of paradigms of treatment and care to bring them more in line with people's everyday realities. And we really need to be thinking simultaneously of working not just at the individual level, but also simultaneously right in the here and now at the socio-structural levels that define and drive logics of care and outcomes of care. Next slide, please. So ultimately what this means, sort of this last slide, is sort of looking, for me, it means that we need large scale social movements for change, and these can be driven not just by everyday communities or people in societies, but also by academics, practitioners, people who exist in society with more access and leverage to power. We need to work collaboratively with groups, not just to design better interventions, but also to advocate for policy change, for change around socio-structural realities, around things like systemic racism and inequalities, and really sort of play with and push the boundaries of the tensions of what counts as meaningful care, and think about these types of practices that poke at these sort of huge power inequalities, these structural inequalities, the socio-political dimensions of life, and imagine that interventions that try to change those dynamics equally count as meaningful for promotion of mental health and well-being. So I think I'm probably out of time. So thank you very much for your patience and attention.
Thank you so much, Rochelle. This was wonderful. Our next speaker that I'm very happy to introduce is Soumitra Pathare. Soumitra, the floor is yours.
Thank you. Can I have my slides coming up? Hi, I'm Soumitra Pathare. I'm a psychiatrist by training. I live and work in India in a city called Pune. I used to live in London long time ago. I'm ancient. This was in the 90s, from 1991 to around 2000, and I've been back in India for two decades. I worked for those who want to know, I worked in South London at the St. Thomas's Hospital. So I'm gonna start off by just quoting what Rochelle just wrote on Twitter, which I think probably encapsulates what I'm trying to say. There are no new ideas. There are only new ways of making them felt. And I think this is important because when I was training in the 90s, for example, I worked with George Brown and Tyrrell Harris, and many of you may not even know these names now, but they did some of the first studies on the impact of childhood adversity on women's depression and the intergenerational transfer of depression that happened because of those adversities. And now I see lots of research again happening on childhood abuse and depression. And I thought we knew this in the 1970s, but clearly we didn't. I have no great profound ideas to present. Okay, I have a very simple thing to talk to you, and this is about a thing that you measure when you do your research in global mental health. This is based on the idea that what gets measured gets done. And I think it's time for us to junk this notion of treatment gap, because a lot of global mental health relies on measuring treatment gap. And it's used as a measure of unmet need. If you look at the dictionary, treatment refers to the act or manner of treating someone. And what happens is that it implies biomedical treatment. Now, you might say that's not what we mean, but that's what the public takes it as. That's what the policymakers take it as. It also implies curative interventions. If you talk to the policymakers and when you say treat someone, then it implies curative interventions rather than preventive and promotive interventions. And so it effectively ignores psychological interventions which are available. Effective psychological interventions are not seen as treatment unless they are delivered by professionals. It ignores physical health needs of people with mental health problems, which is a very important issue, because that people with mental health problems, especially chronic and severe mental health problems, die more than 10 or 15 years earlier than people without those severe mental health problems. So physical health is something that gets ignored in this treatment gap that we end up measuring. And finally, and the most important thing, is it ignores the impact of social policy interventions in improving mental health. And this is important because you might have recently read the study which came out of Brazil, and there have been some similar studies from Indonesia and now also from California, showing that cash transfers reduce the impact, reduce depression, reduce anxiety, and the Brazil study, which is fantastic, which shows a 60% reduction in suicides in people getting cash transfers. There isn't a single treatment that we have which would reduce suicides by 60%. What we have is a social policy intervention. And so what happens is we don't measure very often these things. Can I have the next slide, please? So I want you to junk treatment gap, and instead of that, let's start measuring care gap. Let's start measuring the gap in care which exists for people with mental health problems across the world. And what does care gap comprise of? Care gap would comprise of treatment gap as it is understood currently, which is curative, biomedical interventions. It also includes psychosocial care gap, implying the lack of psychological and social interventions, and a physical health care gap. And if you combine all of this together, then that is the care gap. And I want you to start measuring care gap instead of treatment gap. Can I have the next slide, please? So this is a paper we wrote. You can refer to it. This idea has been explored much more in depth in this paper that we wrote for epidemiology and psychiatric sciences. And thank you so much. I think I've run out of my time anyway.
Thank you so much, Soumitra, just perfectly on time. Great, wonderful. Let's move on. It's my great pleasure to next introduce Tatiana Salisbury. Tatiana, the floor is yours.
Great. Hello, everyone. Hopefully the workmen working on another flat will be quiet for a little while during these 5 minutes. So I'm a senior lecturer in global mental health at King's College London and part of the Center for Global Mental Health. So I'm here to talk to you about this challenge, this issue. So we know that there are many mental health interventions that have been shown to be effective, but we actually don't see them in everyday life. And instead, they're largely confined to live their lives within the pages of journals. So how do we prevent this? And how do we develop interventions that people want to and actually can participate in? So my premise is really simple. We can't go on thinking that expertise alone is enough to solve our problems. In 2019, some colleagues and I used a human-centered design approach to try to address poor mental health outcomes for adolescent mothers in Mozambique. An estimated 200,000 babies are born to adolescent mothers every single day. And although we know that 1 in 2 adolescents, girls experience a mental disorder during pregnancy and the year after birth, the majority of these girls live on the African continent, there really haven't been any interventions to support them that have been evaluated in peer-reviewed journals that are based on the African continent. Next slide, please. Thanks. So to ensure that an intervention has the best chance of success in the real world, it actually needs to align with the experiences, the motivations, the goals, and the challenges that are vital to its delivery and to its uptake. So instead of engaging young girls, partners, families, service providers, and policymakers once an intervention has already largely been decided upon, which is the traditional way of intervention development, we first talked with them to understand their perspectives and to build a relationship. And once we were able to do that, then we worked together to actually brainstorm solutions to the problems and the challenges that they brought up, and to develop some initial ideas of how we might improve the lives, which were then refined through feedback to design a solution that worked for many. So we did not focus specifically on mental health, and actually we didn't even use the term mental health, but we did talk to them about the greater challenges that they faced during pregnancy and the year after birth, and also the outcomes of those challenges. So were they able to find solutions on their own? What were they? Were there things that they did that actually could be used by other young girls and within households and communities, knowing that these have an effect on their mental well-being? Next slide. So the resulting intervention isn't really shocking. So at its heart, it's an antenatal course with skill building, problem solving, social relationship building, and also future planning components. So really thinking about what is it that these girls want to do? What are their goals? What are the barriers to their goals? And how might we address those? And this reflects what many girls miss out on due to not being able to continue in education, these building of soft skills and really thinking about their futures. And while we were doing this, the families also said, well, wait a minute, don't forget about us. So we included a family component to encourage household support of young girls and also to improve relationships within the family. And it's also packaged and delivered in a way that increases its chances of actually being integrated into the existing health and community systems. And so it was decided by the young girls that actually delivery by mothers within their community would be best. That's who they wanted to hear from. That's what they really wanted to take part in, and didn't really need to be part of the healthcare system, although it could be supported by that. So what we found that it's actually possible and optimal to include communities in the development and the implementation of interventions. So the question to all of you is, how can we ensure that communities have the opportunity to actually play a more active role in both research and in implementation? Thank you.
Thank you so much, Tatiana. And I really want this to really be an encouragement to also enter your comments and on these prompts and questions that our speakers pose into Menti, so we can sort of create a bit of a record of conversation. So feel free to really engage the speakers' questions in that space. Our next speaker is our very own Tessa Roberts, and Tessa, the floor is yours.
Thanks very much. So building on what the other speakers have talked about, the main point I wanted to discuss today is how much our understanding of the social determinants of mental health, or perhaps we should say structural determinants of mental health, are reflected in the solutions that we tend to offer to improve mental health around the world. We know that living in poverty, there's a huge body of evidence showing how the social and economic conditions of people's lives influence their mental health, which is now widely recognized. And we know that living in poverty or facing other forms of adversity increases the risk of mental health problems. However, when we're discussing what we should actually do to improve public mental health, we still often focus on the individual and their biology or psychology, and not on the social context of people's lives that influences these biological and psychological processes. This has a couple of important implications. Firstly, there's emerging evidence to suggest that people living in relative deprivation or who face other major ongoing life difficulties are less likely to benefit from mental health treatments. This issue has been under-researched, and there are definite limitations to the existing literature. But the hypothesis that if the causes of your mental health condition are ongoing, then it's less likely to be resolved through either talking treatment or medication is a plausible one. As Michael Marmot put it, we're treating people and then sending them back to the very same conditions that made them sick. We're shoveling snow while it's still snowing. The second implication is that people recognize the futility of treating a problem when a major cause of that problem is unresolved. And I believe that this is a big contributor to what Soumitra mentioned as the treatment gap for mental health problems, particularly among disadvantaged groups. If I see my problem as stress-related, and for example, my stress arises from being a single mother, earning a low wage and struggling to pay for rent and food, then both pills and therapy seem like an odd solution to that problem. Arguably, the best treatment would be increasing my earnings, for example, by legislating for a real living wage. And I'll illustrate this problem further on the next slide. Next slide, please. So the Programme to Improve Mental Health Care, or PRIME, evaluated the implementation of mental health services in 5 lower middle income countries, based on the World Health Organization's MHGAP guidelines. The latest version of MHGAP does mention social needs and social interventions, but it's implemented through primary healthcare settings, where it's a huge challenge to provide even talking therapy with the resources available, let alone addressing people's housing needs and so on. So in practice, the services provided included medication and talking therapy. A key outcome was the treatment gap for depression, which is the most prevalent of the disorders targeted. And this refers to the proportion of people who meet diagnostic criteria who access services for their condition. In general, what the PRIME team found was that making services available made little difference to the treatment gap. I was involved in some qualitative research in Madhya Pradesh, in the Indian site, to investigate why people didn't report seeking healthcare for depression symptoms. And a major reason was that medical interventions made little sense when they viewed these problems as rooted in their social and economic circumstances, which health services are unable to change. And I've included a few illustrative quotes here. I don't believe that these findings are unique to rural India. Similar things have been reported among low-income communities in the USA, for example, and in other settings. And the World Mental Health Surveys found that around the world, a lack of perceived need for healthcare was the #1 reason why people didn't seek help for mental health symptoms. Next slide, please. So as Soumitra mentioned, global mental health has focused primarily on scaling up mental health services to reduce the treatment gap. But what evidence we have so far shows no association between increased coverage of mental health services and the prevalence of common mental disorder. And given what we know about social determinants, I think it's unlikely that scaling up mental health treatment will make a major difference to mental health at the population level. That's not to say that there's no place for medical treatment, but that we should be conscious of its limitations, including that many people will choose not to use it even when it is available. As Professor Galea argued earlier, public health strategies that target the structural, social, economic determinants of mental ill health, however, could potentially shift that whole population distribution. And it would also make far more sense to people who are living with various forms of disadvantage who experience psychological distress as a result. The challenge then is to stop thinking like psychiatrists and start thinking like public health professionals. Interventions could be implemented at multiple levels, from national policy to localized community level initiatives. And there's a growing evidence base now on the effectiveness of strategies such as cash transfer programs that were mentioned earlier, policies and programs targeting key factors such as gender-based violence and working rights, as well as participatory programs, as others have described, in which communities define their own problems and design their own solutions, many of which my colleagues will be touching on more today. So I'd love to hear your thoughts and look forward to discussing what an agenda for global mental health would look like that takes social determinants seriously.
Thank you so much, Tessa. We're at the end of our first Whirlwind Whistle Stop panel, and we would like to take the next 15 minutes to discuss the questions that came up through Menti with our panelists, and the function in Menti to like the different questions, upvotes the ones that seem most relevant to most. So I will just start from the top, and really the most urgent questions people liked was the question, funders are still very much interested in measuring the treatment gap. How do we as small-scale researchers push for funding for more social and livelihood policies for measuring the care gap instead? And I think that's a question mostly for Soumitra, but I think relevant actually across the board, because the structures of research and the way in which these interventions are conducted these days happen under a particular conceptual and funding framework. And how can we intervene on that to change that? How do we switch from measuring the treatment gap to measuring the care gap?
I don't think funders are focused on that. Maybe some funders, there are specific funders which probably fund biomedical research and they might be focused. But many of the global mental health funders are acutely aware of this. In fact, I end up reviewing a lot of proposals and I find that funders are keen on it. The problem very often is that people writing the proposals are actually not making an effort to talk about a care gap and are focusing on treatment gaps. So I think it is really a problem from people who make these applications to funders, not making the effort to think through alternative outcome measures for themselves or think of alternative interventions. And I think if you do that, you'll find many, many sympathetic funders, including many funders who have previously, I won't take names, but funders who in the past would have been very biomedical, increasingly taking an interest in a non-biomedical, a non-curative approach to things. So I think you just need to do that.
Great, thank you.
Can I
Yes,
jump
Rochelle.
in there? Because I just think that's so important, and it kind of makes me think a little bit about what Tessa was saying about, psychiatrists need to stop thinking like psychiatrists and thinking like public health professionals. And I think that there's a very long history that, outlasts whatever the entity global mental health is around critiquing psychiatry's difficulty of keeping people and sort of conditions of the mind and the emotional life embedded in the worlds where those bodies live. There is this constant separation of them, and the whole sort of field of anti-psychiatry and critical psychiatry and transcultural psychiatry, all of these paradigms speak to that difficulty. And I guess one of the big things that sort of locks us in that space is as Soumitra says, the inability to think about these problems as problems. And so maybe one of the ways that we can get around the slow work of sort of paradigm changes, because basically we're asking psychiatry as a practice to sort of become a new paradigm, or engage more with these sort of critical paradigms, I suppose, as the mainstream rather than the fringes, is to really sort of continually push for that multidisciplinary, cross-disciplinary approaches. Because when you have as many voices in the room as possible, then you have everybody talking about the different lenses through which they understand the problem. And so you have an economist talking about the need to think about income generation and access and those types of things. And you have, social workers thinking about different things, and community psychologists thinking about another set of things, and design thinkers thinking about another set of things. And when you have all those people around the table, you then get to a point where you are measuring as many parts of somebody's lived experience as possible. And I think that's something that really needs to happen in the interim, because the other thing we're talking about, which is changing the way people are trained, changing the way we think about sort of disciplines and those disciplinary boundaries and those discourses, is long and slow and hard, and has been happening forever and will happen once we've all retired and gone to do different things. So there needs to be some stuff that happens in the interim. And for me, it's that sort of cross-disciplinary work.
And I think to add on to what has already been said, kind of one of the other issues is that, it is the silo of mental health, and that it's always seen as, we're just doing something specifically about mental health and making it seem like it's one in its own somewhere over here. Whereas if we could just say, also ask our colleagues and work with colleagues in other disciplines and say, you're doing these really interesting projects, can you also include some mental health outcomes within that? Because it's not just that we're saying that we need more funding for mental health research. It's actually mental health should be included as an outcome in almost everything that we do, because of its interconnectivity with so many other outcomes. So that's a really key thing to think about, is that it shouldn't just be a mental health project. And really, we should be trying to make it clear that mental health should be evaluated in any sort of intervention that we're trying to do.
Great, thank you so much. The next question that sort of dovetails with what we've been discussing already, really has to do with funding and the distribution of funding, and how these funding flows also go. So the question is, how do we improve access to mental health research funding for other nations in the global south?
I guess I'd say perhaps the first step is to kind of document the inequalities. So there was a report that came out last year by the International Alliance for Mental Health Funders that showed that I think 2.5% or something like that of all mental health funding for the previous year went to all low and middle income countries, which, when you think that's 85% of the world, is staggering. So I guess the first step in kind of having some accountability is to kind of continue to monitor this and to kind of highlight what a vast disparity there is.
Mhm.
Can I just add to that what Tessa just said? I think we should also change our understanding of the term global mental health. You know, global has always meant geographically global, meaning is it low middle income countries or high income countries? I think there's a lot of global to be done even within high income countries. You know, there are marginalized communities, there are excluded communities, and that needs to be addressed, and that is global. We need to change the definition of global from a purely geographical definition to global as being something that is inclusive of everything. You know, if we want to create inclusive societies across the world, then you need to be inclusive in small places. And so, you know, research funding, global mental health research funding also needs to go to disadvantaged communities in the global north as much as it goes to the low and middle income countries. Because if you're disadvantaged, whether you live in a low middle income country or you live in a high income country, you are disadvantaged. You know, that really does not matter. So I think we need to just rephrase this whole thing of what we mean by global. And it'll also take care of the notion of a very colonial attitude to global mental health.
Yeah.
You know, I would love to get a grant to do some work in South London again, to be honest. I know lots about Lambeth. I lived there for 10 years. I worked there for 10 years. I lived in East London. I lived in Bethnal Green. People who live in London know Bethnal Green. I know a lot about the bits there 20 years ago. I would love to come back and work there.
Yeah, I think that's a really beautiful thought to say that. And it's something that I've always been thinking of is why can't we just find shared challenges and then look at where those are happening in the world and try to figure out, you know, are there problems that we can solve not only for this one community, but to other communities that are experiencing the same sort of issues. And so that could be one way as well that we think about how do you expand this idea of global mental health and make it truly global and stop these like odd delineations between, you know, what can get funding for this and what can't.
If I could jump in there as well, just because what strikes me sometimes is that the social determinants of mental health are themselves kind of a universal language through which we can go and look in different places to see how the challenges are actually quite comparable. One of the questions that we have in our mentee group, however, also relates to the fact that we often say that these ideas are actually not new, that we have been doing and discussing the social determinants of health, of mental health for a long time, but how can we actually make progress in solidifying that global material conditions are meaningful determinants of mental health? Like just shifting the conversation more broadly, which is also a concern of the center itself, with a bit of a history of this having not been making the kind of progress or breakthrough that we would like to see. Do we have any thoughts on how to operationalize this conversation that, and also is the global, like our material conditions only important as a way to mental health outcomes, or is there a conversation to be had? Why is it framed in health terms at all?
I mean, there's something that has been running through my head all day. That's sort of like, it sort of links to work of sort of Black feminist scholarship. That description is distraction. But they don't say it that way, but I sort of feel like that's, for me, what I feel like has been one of the big challenges in sort of global health, global mental health. We're very good at trying to describe problems, right? Like, so we spend a lot of time, I think, in the field so far trying to describe them to justify that they are a problem. And I think this sort of ties into a lot of other inequalities and inequities in terms of how evidence and methods are valued, but that's a whole other panel, so I'm not going to jump too far down that rabbit hole. But for me, I sort of think the way that we move forward is to fund work that is actionable rather than descriptive, and or at least be thinking about combining actionable work and descriptive work in the same project. So I just feel like there's these false like dichotomies and splits that happen all the time in research, where we think, oh, first we must describe this, then, and once we've described this, then we can understand this, and then we can act on it. And I just sort of feel like that sort of practice not only erases the power of sort of indigenous knowledge in communities, where they, with their voices, tell us what's going on and tell us what the problem is and tell us what they think the solutions are, but it also sort of keeps us locked into these cycles of producing the new description of a new, like just keeps us locked in these patterns of description, which then distract us from acting on the problems that we've described. So for me, I sort of would think we sort of move forward by saying, okay, more and more calls or frameworks or funding for action-oriented research that is embedded in change that's happening now, as opposed to sort of just continuing to build on our canons and canons of things that never get read or may never get read, or just in order to feed the machine that is the production of research and academia. So I guess for me, it's sort of about moving further into spaces of combining activism and scholarship, so that your research is consistently interested in action-oriented outputs in the here and now.
Yeah, and does that also relate to your idea of revolution, Rochelle, which you bring up?
Yeah, I mean, gosh, I really didn't want to put that in the title, because I was like, this is recorded, it's gonna get up on YouTube probably. My mom's gonna call me and say, why are you talking about revolution? But basically, I think it sort of is, in the sense that we need to change the reason, I suppose, if we're claiming to be involved in a project of improvement around inequity and justice and trying to serve justice, then your research must be about revolution. How could it not be? If it isn't, then are you not just reifying the structures of oppression and inequity that are maintaining the world in the way that it is? And I think that you can think about revolution on scales. It's not that the whole thing gets knocked over all in one day. There is sort of a small wins paradigm or mechanism to thinking about social change and also thinking about action related to social change. And so I just sort of really feel if that becomes our orientation of revolution, of change, of social change in each aspect of how we're working, your work starts to look different. Right. So you change the way you think, and then the actions follow, I suppose.
Wonderful. Thank you so much, Rochelle. I'm afraid we're at the end of this cycle of our panel discussion cycle, and we will have to segue right into the next panel. But I really wanted to thank you all for your wonderful contributions. And we have a lot of specific questions for all of your projects still in the Menti chat, and we will make sure that these are all being transferred forward to the speakers on the details of your interventions and thoughts. So they're not lost. We will collate them. And without much further ado, I will hand it over to Tessa to moderate the second half of our session.
Great, thanks. Next up, we have Francisco Ortega. Francisco, it's
Thank you, Tessa. Good afternoon. Well, as an introduction, I'm professor at the Institute for Social Medicine of the State University of Rio de Janeiro, also visiting professor, Department of Global Health and Social Medicine at King's College London. And I am changing institutions in the next month because I have been appointed as research professor of the Catalan Institution for Research and Advanced Studies at the Medical Anthropology Research Center of the University of Tarragona in Spain. So this presentation is based on some work I have done in collaboration with Christian Montenegro and Leandro Wenceslao that are here acknowledged. So the consolidation of global mental health as a field has been accompanied by a strong call for interventions to be contextualized and adapted to the cultural and social realities. In this logic of implementation, culture and context constitute layers that interventions penetrate with more or less success, acting as obstacles or enhancers for mental health and well-being. The example from Brazil evinces how within local mental health systems contexts behave in ways
We've had a problem with the connection. Are you still with us, Francisco? There must be a problem with the connection locally. Maybe we should go to the next speaker and then we can come back. So I'll pass over to Felipe Shabzum and hopefully we'll get Francisco back shortly.
Okay, can you hear me?
Yes, perfectly.
Yeah. So good afternoon, everyone. First of all, I would like to thank the organizers for inviting us to join this table. It's a pleasure and an honor to take part in this event. My name is Felipe Shabzum. I'm a clinical psychologist and a PhD in public health and social sciences. I'm currently a researcher at the section of psychiatric epidemiology at the Institute of Psychiatry at the University of São Paulo Medical School, and a founding member of PLASMA, which is the platform for social research on mental health in Latin America. Also undersigning this presentation is Professor Laura Helena Andrade, a clinical psychiatrist and the coordinator of the section on psychiatric epidemiology and associated professor at the University of São Paulo Medical School. All contributing members of the team are listed in the final slide. We are going to present very briefly an ongoing project that we are currently developing here in São Paulo, Brazil. So next slide, please. When we were invited to join this table, the organizers have provoked us to answer the following question: how can global mental health better consider the social context in which mental health problems arise, acquire meaning, and are responded to? To answer this provocation, we have chosen to discuss two key ideas. The first is the idea that global mental health could better consider the social context by exploring how local problems are associated with suffering and distress, and in this particular case, what kinds of problems people living in the peripheries of São Paulo have endured during the COVID-19 pandemic, and which contingencies these new scenarios have promoted in terms of changing forms of life, generating distress and suffering. The second is the idea that global mental health could better address the social context by working together with community members to produce care and support by building common knowledge about what mental health problems actually are and what do they mean for the people living under adverse circumstances. So as you can see, our project is in close dialogue with our previous colleagues that have spoke before me. Next slide, please. Our project, entitled the Solidarity Neighbor Network of Sapopemba, was built as a contingency plan to the emergence of the COVID pandemic. Since the arrival of the virus in Sapopemba, we felt that the action was actually needed, and even more so, it was important to understand what was going on in the territory that people was referring to as arising mental health problems. So we were just to start a field work, an ethnographic field work, and we were confronted with this new emergence of the pandemic, and we felt action and an action research project was actually necessary. And what we did was that we gathered a group of local volunteers and provided them with simple training in empathetic listening. Phone credits and supporting material were provided to community member volunteers to reach out to neighbors who reported being in a situation of distress and willing to receive a supportive phone call. Over a period of 3 months, we uphold weekly meetings with these volunteers to discuss the cases that they have been finding. In these meetings, we could discuss with the local volunteers what were the problems people were facing and seeking potential pathways for providing support. So this was our main source of information and data. The research part of the intervention was upheld in these meetings. And at the same time, the whole community was getting mobilized to support each other. And we were providing like a background, a backstage support to the supporters in the community. Next slide, please. To wrap up this presentation, there are 3 core ideas that are standing out from our research process and that we would like to share with you. First is the idea that mental health problems are part of a dynamic social context that is always in movement. An important issue is then to understand the social changes taking place in the territory and what do these changes mean, not only in terms of suffering and distress, but also in transforming local forms of support and care on which people rely upon. To grasp the social context, global mental health should explore and comprehend the new imbalances that are taking place at the local level and the ongoing changes in the ways communities produce and reproduce care. The second idea relies on a problem that is associated with how communities conceive and understand what is framed as mental health problems. Very often, we found that psychiatric diagnostic labels, or even more broadly, the language of global mental health, makes it difficult for community members to understand the difficulties faced by their counterparts. For this reason, people frequently redirect their peers to mental health services, even before understanding the concrete needs. So there is like what is, Soumitra was talking about this gap, and I think here there is a gap in the whole notion of what actually is mental health, what we are calling mental health. In this sense, standardized diagnostic labels are frequently mobilized as empty signifiers to address the other's mental distress. In these cases, the community often does not have a clear meaning about what they stand for, although they use these concepts in a very intense way. This process has individualized problems and maintained existing forms of support and care away from issues that are framed as belonging to the mental health domain. So the forms of care that are actually in place in the territory, they do not apply anymore because the problems are framed as mental health problems and not problems of the community anymore. So, and this idea leads us to the third and the final point, which is related to the role that communities can play in situating mental health problems into the social context. A problem that emerges here is related to the challenges for global mental health to reach the local context in such a way that it integrates communities into care provision and not by setting them apart from it. To this end, we have questioned how to promote and scale up spaces for co-production of care and care intermediation in a broader way than those solely relying on formal mental health services. Next slide. Just to finalize, I hope this presentation was clear and illustrative, although we have very short time to present. And so far, these are only preliminary thoughts, but I hope this could clear up some ideas we are gathering from our project. Thank you so much for your time and attention.
Thank you very much. That was a fantastic overview in a short space of time. I think we now have Francisco Ortega back, so it'll be great to go back and finish what you started there, if you're now online. Over to you, Francisco, if you're with us.
You have to unmute me. I am muted because there is.
We can hear you now, so that's fine.
Okay, I go on my cell phone. 1 second, please.
We can hear you fine at the moment.
So, okay, so I go ahead. So one of the divergences between global mental health and public mental health care in Brazil regards the role of cultural differences within mental health policies. While global mental health attributes in one way or another high relevance to the cultural aspects of mental health, these are concealed with a mental health service in the country, a process that we call silencing of culture. This erasure and internal contestation of culture are related to the imaginary national understanding of Brazil. According to this understanding, cultural uniformity is for Brazilian anthropologist Darcy Ribeiro the most important consequences of the formation process of the Brazilian people as an ethnically homogeneous nation, integrating cultural, racial, ethnic, and regional differences. Despite the national narrative of cultural uniformity, Ribeiro and others consider the Brazilian society as profoundly stratified, However, the stratification that receives policy attention are not those of culture and ethnicity, but those of class. This cultural understanding has influenced the Brazilian psychiatry reform, as well as mental health policies and services organization in the country, which have privileged class stratification and socioeconomic inequality at the expense of cultural diversity. Ongoing criticism of this emphasis advanced by indigenous, Black, and LGBT movements has so far not significantly impacted the theoretical and practical foundations of Brazilian mental health care. Against this background, the significance of cultural differences for causes, courses, and outcomes, as well as cultural explanations for mental distress, were neither incorporated into mental health policies nor into the practice of most professionals in the country. Conclusions. The implementation of any given intervention can either succeed or fail depending on its local uptake. Nonetheless, while context and culture need to be adequately understood in order to address the mental health needs of a population, they are simultaneously subjected to local negotiation related to history, identity, and epistemic practices. Therefore, a meaningful global mental health intervention in countries like Brazil cannot merely assume context and culture as something directly accessible. Cultural determinants are being actively, although not consciously or deliberately, hidden at the local level. A careful examination of local and historical configurations, which in this case involve the process and patterns of national identity formation, is necessarily before developing meaningful interventions for practitioners and service users. Rather than static layers in which intervention can be adapted, it is important for global mental health to recognize that culture and context are internally contested and that their meaning and relevance are rooted in local history and identity. Critical concerns about exporting knowledge and practices need to be supplemented with a careful examination of the internal complexity of culture and context and how they are made visible and negotiated alongside global and local policy ambitions. Next slide, please. Now, some questions. How to think beyond simplistic assumptions about implementation logic in global mental health. Second, how to balance an attention to class differences with an attention to cultural differences to produce meaningful mental health interventions in countries like Brazil. And finally, how to negotiate culture and context alongside global and local policy ambitions. Thank you very much for your attention.
Thank you very much. That was perfectly timed. Just a reminder to please, if you want to respond to some of these questions or provocations or pose questions to any of the speakers, do use the Menti panel and we'll come to those in the discussion shortly. So our next speaker is Georgina Miguel Esponda. Over to you, Gina.
Thank you, Tessa. Thanks so much, everyone, for joining us today. I'm a postdoctoral associate at King's College London, but today I'll be sharing some reflections based on my PhD work which looked at the implementation of a mental health program that was delivered in primary care clinics in Chiapas, Mexico. This was done by the non-governmental organization Compañeros en Salud. I finished this work in 2018, but until now, this program continues to provide mental health services in remote and rural communities to over 500 people every year who experience anxiety, depression, and psychosis. Just about 7 years ago, before this program started, these communities had virtually no access to any health services unless people embarked in very expensive and long trips to the capital city of the state. So increasing the availability of services for this population has been a huge achievement. However, there are two things that I'd like to discuss today. First of all, has increased access to mental health services addressed all the mental health needs of these communities? And going a bit beyond that, can we expect health systems to even fulfill mental health needs of populations? Next slide, please. So first of all, let's see what the mental health services delivered by this organization look like. This program is grounded in equity principles under the strong belief that healthcare is a human right and that everyone should have access to it. It has been developed through an iterative process throughout 7 years managers are constantly identifying the emerging needs of clinicians and users and coming up with the strategies to address these needs. So the organization has ensured that there are primary care doctors who are trained to deliver mental health services, so they can screen for mental disorders, they can prescribe medication, they can deliver psychoeducation. There are printed materials to facilitate the delivery of these interventions. The organization also ensures that there are that the pharmacological treatments that are needed are available. They hire experienced doctors to provide face-to-face supervision at least once a month to primary care doctors. More recently, they have also hired psychologists to also provide training and treatment in complex cases. They have been recruiting and training community health workers from the communities where they work to provide home-based support to people with mental disorders and their families. And all the materials to aid the delivery of these services are produced in an accessible language and using local idioms. So two things have been really essential and really huge achievements. And one is ensuring supply, and two is making sure that whatever is supplied is accessible. So within the doctor's capacity and also relevant for and useful for users. However, the dropout rates are very high. So around 50% of people who seek services do not, for mental health, do not go back to the clinics for a follow-up consultation. Next slide, please. So once one of the doctors running this program told me that even if their services were perfect, so they were the best possible quality, many patients would continue experiencing depression or anxiety. And this doesn't mean that services and the highest quality services shouldn't be provided, but it just means that they are not enough. And this might not seem surprising given what we have heard today from all previous speakers. I've listed here some of the most salient issues affecting these particular communities. So again, it doesn't come as a surprise that without tackling the source of distress lived by these populations, even the best quality treatments are just not going to be sufficient. Next slide, please. I want to pose two questions for reflection. First, we still have a critical issue to solve, which is improve access to high quality treatment. Treatments that are relevant, that are appropriate, that are humane, that place at heart the needs of people. Users that did attend and benefit from the mental health program of Compañeros en Salud report that doctors were good listeners, gave them relevant advice, and that they feel that doctors understood them and wanted to help them. So how do we ensure that all people who need and want mental health treatment have access to it? But second, how do we stop piggybacking everything on the health system? How do we make intersectoral collaboration work, particularly in settings where welfare systems might be almost non-existent, so that we can further improve the mental health populations? Next slide, please. And that's it for me. Thank you all so much for listening, and a big thank you to everyone that through many hours of conversations helped me shape these reflections.
Thank you so much, Gina. That was great. Finally, for our last lightning talk of the day, we have Dörte Bemme. Dörte, over to you.
Thank you so much, Tessa. So my talk today is entitled How to Scale the Local, Thinking with Open-Endedness in Global Mental Health. Next slide, please. I'm an anthropologist in and of global mental health, interested in the globalization of psychiatry as a practice. In other words, I study how mental health care travels and how it is implemented in different settings. So what I'm presenting to you today is based on ethnographic fieldwork with global mental health practitioners. Now, I want to start with the notion of scale. So global mental health has framed its main goal as scaling up evidence-based mental health care, especially in low research settings. And for proponents of this project, the idea of scale expresses the humanitarian desire to reach and include those left out. For critics, on the other hand, scaling points to the expansion of sameness at the expense of diversity. And the practices of scaling up do involve the proliferation of universals, be they disease categories, guidelines, such as NIH-GAP here on the right-hand side, standardized packages of care, or medication. But at the same time, both within and outside the global mental health community, mental health professionals know that context matters greatly. How mental distress is understood and experienced, what causes it, and what constitutes meaningful care is contextually shaped, as we have heard from all of our speakers on this panel today. Context, however, must be understood as more than culture or local idioms of distress. It is a dynamic assemblage of intersecting layers, including legacies of inequality, war, colonialism, racism, as well as the effects of the material environment, labor arrangements, religion, gender relations, and the specificity of health and welfare systems where they exist. And this aerial photograph here in the corner gives us a sense of the unequal life worlds and healthscapes context can refer to, often in the same place. So given this, what are the practices of scaling that engage the contextual specificity in communities? Or put differently, how can one scale the local? Next slide, please. So the key idea I want to share today focuses on open-ended knowledge practices that global mental health practitioners use. Open-endedness here refers to a way of thinking in which neither mental health nor context are stable entities, but require constant adjustment. Next slide, please. By way of examples, I'm focusing on two simple phrases that global mental health practitioners often use when they think about scaling the specificity. The term active ingredient is on first glance a pharmacological model of efficacy, but the notion is also often used in complex social interventions to describe a generalizable idea that needs to be realized in context in order to be activated. For example, Professor Graham Thornycroft once spoke about the active ingredient in stigma reduction is face-to-face contact with a moderately ill person. And this formulation doesn't prescribe where and how exactly this contact needs to happen. It could be in a church, a classroom, a neighborhood, or online. So despite its pharmacological framing, the idea of an active ingredient was an open-ended, capacious term. Similarly, the common phrase, what works, or this question often being posed by evidence-based practitioners, is often used to express the need for evidence, but also for constant tinkering in an open-ended process. And here I'm using the example of the Friendship Bench in Zimbabwe run by Professor Dixon Chibanda, a counseling intervention that uses grandmothers from a community to deliver care in front of primary care clinics in Harare. The intervention scaled by constantly asking what works, and by using a framework called theory of change in a highly participatory way. In this process, the grandmothers were involved in redesigning the intervention, defining key concepts, therapeutic practices, and measurable indicators for the evaluation. And in a recent publication, I have called such open-ended knowledge practices a form of contingent universality that is true until the next iteration. Next slide, please. So let me end on a few takeaway thoughts. In a nutshell, what seems to work in scaling with specificity came down to the following. Change your concepts, including the problems, outcomes, and measures when they do not resonate. Ask others often. Design with change in mind and plan to be surprised. But I also really want to end on a note of caution, and that resonates very much also with the panel on racism in this conference, that practices like co-production or open-ended knowledge practices, like the way I'm describing here, are not neutral. All processes of integration, iteration, or participation are shaped by power dynamics and can themselves be tokenistic, ritualistic, or even silencing. And because of that, I think it's crucially important that we continue to ask whose knowledge counts. Thank you very much.
Thank you, Dörte. Lots of food for thought there. And thank you so much to everybody who has entered questions into the Menti platform. So we have about 15 minutes or so for discussion with the panel. The most popular question so far is, how do we approach global mental health as a global concern, given the necessity of resource-intensive cultural adaptation that's needed for more stringent RCTs to be done to build an evidence base? I think this was for all of the panel. I don't know if there's anyone who would like to comment on that.
Can you repeat the question? Is it about the resource intensity of building what's necessary to actually adapt and to really do meaningful work on the ground, and which also I believe ties back to what Francisco was talking about. Like if we need a different understanding of culture and context as internally contested and grounded, and also perhaps what I'm speaking about in terms of like adaptable processes that continue to be in touch with different layers of culture and context, that this actually requires quite a profound engagement that cannot just be kind of like an in and out sort of helicopter type of intervention, but really needs to be much more structurally embedded. How to find the resources for that? I don't think I have a really good, straightforward answer to that, but I'd be curious to hear what others think.
I guess in terms of approaching it as a global concern, I guess the key point and what we can see from like various examples that have been presented here today is that there are many commonalities in different settings. So there's common problems that need to be tackled in different contexts. And I think in that sense, there are probably some lessons that can be also, some learnings that can be applied across contexts.
Can I say something?
Please.
Yes, I mean, there are two different questions. One is how to balance this need on global mental health interventions and scaling up and reproducing, implementing in different settings, and at the same time being loyal to the context. And this context and culture, which is in some places, like for instance, in my presentation in Brazil, dynamically contested. That is one point. And another thing is how to get funding to do that kind of research. Obviously, if you go to a funder and say, well, look, you cannot study the local context, but because this is internally contested, you need to know the dynamic of identity formation, of even national identity formation, etc. Probably no funder will give you money. So that is the tension, I think, in this whole issue.
Yeah, thank you very much. I guess one of the things that's coming out a lot in the chat is kind of the division between what should be dealt with within health systems and what should be dealt with outside. So somebody said they'd really love to hear the panelists' thoughts on Dr. Miguel Esponda's question. Are there certain mental health needs that health systems absolutely should fulfill versus those that should be addressed by other stakeholders? Does anyone want to comment on that?
I mean, I think there are very clearly there is people that want mental health services, that want mental health treatments. And we know that, for example, in terms of pharmacological medication, maybe not everyone benefits from it, but some people do. So I think possibly one way to look at it is like what level of severity maybe of a condition should be treated by the mental health system. And I think with very serious cases, like there is an argument for, or there's definitely a need again for mental health services. I guess like that is not to say that there's other things. So I mean, we talked a lot about here today about employment and generally like the role of income in the distress that is lived by many communities. There's other things like gender-based violence, and I think all of in many health systems, I think we see that, for example, take an example of gender-based violence, like that is something that currently, at least in Mexico, it is expected that the primary health system is going to deal with. Like screenings happen there primarily, and then all services are supposed to be delivered through there. But I think that is a very good example of an issue that really needs to be addressed outside of that health system.
Can I say something? I think there is one issue that it's striking me throughout all the presentations, and I think it's something we should discuss further. It's because I think there is an unresolved problem here that is relying on the base of many of the presentations and the discussions, which is the transposition of the discussion on mental illness to the idea of mental health. And I think when we are talking about mental health like as a general issue, and we are framing and discussing the social basis of mental health and the ideas of suffering and distress and all this that is appearing, it's very hard to frame the problem within the health system alone. So once we are discussing mental health as this general big term, we should be discussing welfare systems as a whole and in a broader framework than a health problem. And this was a problem in Brazil because all the discussion on mental health problems were always framed as a health problem. All the mental health services are framed within the health segment, the health sector. And we have very little policies that are broader than the health section, than the health sector. There is very little discussion on integration of other welfare policies. So I think the question would be very well that there is this problem about mental health and about mental illnesses that should and must be framed within the health sector, but we should look at it more broadly. So I think there is this discussion that should be better framed as a whole.
Can I say something? Can I jump in? I just want to jump in exactly between Georgina and Felipe, also from my experience in Brazil. I mean, I really agree with you, Georgina, but we also have, I mean, when you see primary care practitioners in Brazil, many times the other experience, sometimes they only have medication to give for some activities, and they know that that is not a mental health problem, but that has to do with what Felipe said about I mean social work and other things. But the doctor has no a job to give to that person, so they only have something. They only have medication. So some people, they criticize them because they say, well, you are medicalizing everyday suffering and structural violence and etc. Well, they are not. It's you know the weapons that they have in their hands. And in some places, the health sector is the only place that reach those communities with some health units, etc. But I think it's important, and we've been done a lot of work now working with community leaders in several favelas in Rio de Janeiro. What they do is really interesting, the whole work around mutual aid activities that has been conducted frequently with the aid of health professionals who were in the health units, etc. So this collaboration, this synergetic between health sector and more grassroots activities are very important. And during the current pandemic has been very important in some places in Brazil.
Absolutely. I can also see Rochelle in the chat suggesting that social prescribing models might be something to be worth considering. How do we make social prescribing models link in with health systems in order to address some of these wider needs that can't be addressed through a medical model? I've got a question specifically for Felipe here, someone's asking if there's been a change over time in embodying mental distress as empty signifiers, giving them a status and bypassing listening to people. Do you feel like there's been a change in the way that we kind of conceptualize mental disorders and the extent to which we kind of listen to people's own ways of conceptualizing their experiences?
Not sure if I understood very precisely the question. This idea of empty signifiers is something that it emerges very recently in our work, particularly because we are dealing more with the notion of care than actually with the notion of the experience of having a diagnostic or a diagnostic label. But still, what we are actually finding is that very often when someone, the way people refer to like, oh, he has a depression, so it's not my problem, I don't even understand anything about it. What is depression? It's a medical condition. And then when the volunteers of our project would call and say, but look, explain me, what is it that you're facing? And someone started to describe their experiences and bring meaning to what they are actually passing through, people in the community could better understand and could provide support that beforehand, when they only had the diagnostic itself, there was nothing that could be done, you see. Like before, it was a medical problem, and so it should be dealt with by the professionals and the formal mental health services. And once people started, and we realized with our volunteers that they simply stopped using names of conditions to describe the suffering that their counterparts were facing during the pandemic. So in the very beginning, everybody were like, oh no, it's a problem of anxiety, it's a problem of depression, it's a problem of, they had names for others' problems. But once we started working in close relation and give it a call, try to understand what is actually happening to that person, the diagnostics are not needed anymore. So this is something that came up and we call it as empty signifiers. Not sure if I answer correctly the question, so please let me know.
No, I think you answered it perfectly there. That's great. I think we've got time for one more. This one I think probably relates most to Dörte's presentation. Someone said, scale is such an important conceptualization with respect to context, but does time or temporality also impact our ability to grapple with this? It's quite a big abstract one for you there, Dörte.
Yeah, and I'm not sure I fully understand it. So scale, can you perhaps read it again one more time? Sorry, Tessa.
Question is, scale is such an important conceptualization with respect to context. How does time or temporality impact our impakt to grapple with this?
I think what I was trying to sort of show is that the instantiations, when I think scaling was sort of successful, is when it thought of itself as a process in time, and that it's not like a contained scaling is like the reproduction of sameness across time and space, but as a process that is actually a never-ending engagement and communication with the environment and the communities and the people you're trying to engage, including your own assumptions. And so the temporality of scaling was kind of, in a way, not, you know, it's not just, I think what I'm really interested in is how scale is actually very different things, and it contains a lot of different projects, like a certain like humanitarian sentiment, but some people associate with it sort of like an expansion or like almost a colonial and capitalist type of endeavor that wants to sort of be all encompassing. So it has all these different meanings. But what I found that working with people who do the actual work of scaling, it is exactly this kind of like forever unfolding process of communication that is actually never really complete, where you cannot actually say you have successfully taken. And that's why I thought active ingredients is an interesting concept, because it is exactly, and it relates a little bit to what Felipe says about empty signifiers, except this is almost deliberately created to be a bit empty in order for people to be able to take it, make it yours, realize it in context, activate it and make it actionable, as Rochelle perhaps said earlier. So there is something to the language of mental health that is capacious, that is very unspecific and unprecise, and it allows you to connect to a number of differently framed problems and articulate them through and in the language of mental health. Whether or not that is a good thing is not actually, there's no easy answer to it. I think it can go different ways, but I think I'm veering away from the actual question of temporality. I think what I was trying to say and what my experience is in working closely with global mental health practitioners, that scale and scaling are many different things, and we have to understand it in their specificity and as a process that is folded towards sort of an infinitely adjusting horizon if you want it to be in any way successful. But that always poses questions for evidence-based knowledge production, because how do you measure things when in the middle of a trial you change what the thing is called, or you change the practices or the set of therapeutic practices because you realize you might have to. So it poses a problem for the production of knowledge, but not necessarily to action and to care and to helping. So this kind of adaptive way of tinkering, of muttering through, of improvising and responding to to problems that are framed in different terms is actually quite useful. I think where it comes up against science and knowledge production is in the way in which we design our trials and what we consider then outcomes and evidence.
We're coming to the end of the session. Thank you so much to all of the speakers from the previous panel and to this one. And thank you so much to all of the audience members for some really thought-provoking questions. We're going to try to end by sort of crowdsourcing some key take-home messages. So I think Nathan is going to, it's just posted a link in the chat where we're really keen to hear your thoughts on what are the kind of key take-home messages that that you take from today in terms of how could global mental health better consider social context. So please do enter your responses there and we'll have a nice visual records then of what are we taking away from the discussions today. No jargon, engage communities. Any other key take-home messages from the discussions across all of these? Inclusion, true co-production, engagement, humility. Some great stuff coming in here. Thank you so much. Hire from the global south. Find shared challenges. Collaboration, power matters. Global, locally, co-production. Fantastic. So we'll compile all of the questions. There was definitely some really useful comments that we didn't get time to discuss. And we'll also compile this final kind of visual display of key take-home messages according to everyone who's participated today. So I just want to say a huge thank you to the speakers and to everyone who's participated. And I'll hand over to Craig for closing remarks for the day.